Hello all. Hello all. Hello. I am Cindy James again, and I would like to welcome back our keynote speaker, Elijah Behr, who will talk to us about Brugada syndrome from fetal to 50.
Thanks, Cindy, and really enjoying the meeting, the quality of the talks, and all the toing and froing. And I'm sorry that I've been as vocal as I have been, but you're going to have to listen to me again for a bit longer. So Brugada from fetal to 50. So this is going to be a bit of a story about maybe the life course of it, trying to refer mainly to the pediatric aspects of it, given that the audience here is mainly pediatric. So not necessarily going to be about single gene disorders, as the title alludes to. I mean, Brugada we thought of as a primary electrical disorder, but those of you who know me will know that I don't believe that, and that it's got a subtle structural substrate underlying it. But we still know of it as an ECG diagnosis with this characteristic type 1 pattern that's persistent, transient, or provoked. The genetic associations are about 1 in 5 probands will have a likely pathogenic variant in SCN5A, although that's not always required, because we know that common genetic variation is incredibly important to the Brugada phenotype, and polygenic risk scores underlie the condition with or without a sodium channel variant, and also probably mediates penetrance and also drug provocation effects. So quite a complex genetic disorder. I'm going to briefly talk about diagnosis before we launch in, because it's something critical I think we need to really get to grips with, and will cause maybe more consternation from Andrew once I touch on it. But the ESC guidelines have recommended, as do the other international consensus documents, that if you see a spontaneous type 1 pattern, that it's Brugada syndrome. So we've been using drug provocation, and this is the Ashmolean test I showed you before, the sodium channel blocker test, that it's positive. But we know that in individuals with AVNRT, that there's a high rate of Ashmolean positivity, and even in healthy controls, in this particular Turkish population, these were actually just convenient people who came from the university, who had agreed to have it done in the university in Istanbul that Can has Demir ran the project from. They all have their positive responses way and above the level of Brugada syndrome in the general population. And this Israeli study from Sami Viskin and colleagues showing that emergency department attendees with fever were much more likely than those without fever to show a type 1 pattern to the level of around 2%, which again is not consistent with the type 1 pattern being Brugada syndrome at all times without provocation. And we've recently published earlier this year a clinical trial in healthy subjects who underwent Ashmolean provocation testing. And these healthy subjects had I think I mentioned to you already, 3-generation family history clear of sudden death, normal ECG, normal echo, normal 12-lead Holter, normal MRI. We went through the full gamut of them. And they had type 1 patterns in 3 of them with sodium channel provocation. So these earlier data prompted the Shanghai consensus to define a point scoring system for Brugada syndrome. And you'll notice here that fever and drug induction of the type 1 pattern were given lower points than the 3.5 to actually score definite Brugada syndrome. I think they should probably be slightly lower on the fever as well as the sodium channel blocker challenge. And there are other factors that came in to this whole point scoring system, including the background clinical history and the family history. And indeed, you could also add in the small SCN5A variant half point as well for this scoring system. What we did in the ESC document is not to counter that, but on the basis that that was still a consensus statement with no actual data behind it, solid data behind it to back it up, and that it would evolve over time, we preferred to be a little bit more generic and downgrade the strength of the sodium channel blocker challenge-induced type 1 pattern as being significant, unless There were these associated other findings, and if not, then you may consider a type 1 pattern to be Brugada syndrome, but really trying to lower the threshold, and there's actually a consensus statement that should be coming out next year to give greater guidance about sodium channel blocker provocation testing that should be sponsored by all the societies, including HRS. In terms of prognosis across the population, the finger study data still probably holds to some extent, in that we know that asymptomatic carry the lowest risk. Those with syncope carry intermediate risk sufficient to consider ICD, and those who had resuscitated sudden death have the highest risk. And the ECG appearance, the type 1 pattern, drug-induced carries lower risk, asymptomatic the lowest risk. Spontaneous has higher risk, and if asymptomatic, a borderline risk. Is that really suitable for ICD or not? What about pediatric risk, though? Because the finger study was not based on young patients, on children. It was based on predominantly on adult patients having follow-up subsequently. These are data that came out from the Nantes group with a multi-center study, and showing that pediatric risk in particular was associated, like in the finger study, with syncope and with the type 1 pattern. And if you had both, you were at the highest risk possible. So the factors that are present in adults are also present in children in terms of risk. There was also more SCN5A related disease and greater risk associated with that in the pediatric population of this initial study, and quinidine usage appeared to be useful, or hydroquinidine in the French experience particularly, appeared to be useful in mitigating risk. You've seen this diagram before from the earlier study, and that we had that high level of Brugada syndrome yield amongst unexpected sudden deaths when you investigate family members. But I wanted to just prompt you that you may think that's unbelievable yield in the pediatric group, but that's proportional, and that the absolute numbers at risk are still low because of what I showed you earlier as well, that the pediatric population in relation to the young adolescent and young adult population is still going to be at lower risk in general. So the actual absolute numbers of Brugada syndrome, young patients dying suddenly, is actually still low. It's just proportionately, we may be not recognizing the Brugada syndrome contributes. But from that study as well, what we did notice was that the younger the age of the decedent, the less strong the Shanghai score was in that decedent's first relative, the one that had the greatest indication of Brugada syndrome in their evaluation, which suggested to me that actually it was the young person that was presenting the strong proband, and that you don't actually necessarily have that much heritable risk, polygenic heritable risk in the parents. It's combined in those children for that significant risk. So children are a little bit of a challenge in trying to understand their risk with Brugada syndrome. And there have been some insights about risk in children from the Sabra survey. This is led by Anat Millman and Bernard Balhassan in Israel as well. They took data from multiple centers. I think it was around 40 or 50 centers in total, either aborted cardiac arrest or patients with ICD implants in for primary prevention that then had a first arrhythmic event. Sorry, it was 23 centers, apologies. 678 probands, of which the majority were male. They looked at the age at first arrhythmic event, and the Sabras patients were compared to a Brugada syndrome registry from about half of those major centers where they had large numbers of patients, and you'll see the age distribution of those with their first arrhythmic event compared to the registry is actually very similar, a very similar distribution. There are not a lot more young people presenting with arrhythmic events. They're similar to the general population distribution of Brugada syndrome in these registries, with the same peak in the middle. The age alone is not a predictive risk in a Brugada referral population. What about gender? So age is normally distributed in males. Those are the purple blocks over there. But in females, the distribution is bimodal. So in fact, female children seem to be at higher risk than male children, and elderly female individuals are at higher risk than elderly males, which is an interesting thing to think about when we consider the hormonal influences on risk in Brugada syndrome and the effect on sodium channel function. And in terms of other features of risk and gender and age, we seem to see that females have less type 1 Brugada patterns and less inducibility at EP study, yet still go on to have arrhythmic events. And so risk stratification in females needs to be different, and risk stratifications in children needs to be different. And also with ethnicity. Asian patients, usually more male adults. I don't know why it's going on by itself, but anyway, it's deciding to do that. Usually male adult patients, less pediatric patients in the Asian population. It really focuses on male adults, which I think is also typical of the presentations in Southeast Asia, and more often with aborted cardiac arrest and a spontaneous type 1 pattern in the male patients. And the intriguing aspect is also fever as well. Fever as a precipitating factor is much more common amongst children than amongst adults, and slightly more so amongst females than males, but these are very small numbers, so I wouldn't necessarily read that much more into this when you come. It's not that granular. The data, they're not that granular, these data. There's some very interesting pediatric differences as well. And if we look at a large French referral population with the age at diagnosis, here they have a cohort of 1,600 patients, the largest probably in the world. The majority male, the mean age 45, but here the 1 to 17 age group is obviously small, 52 patients, a third with a type 1 pattern, much like the adult group, but there were slightly more females than in the older adult group. More were diagnosed by family screening, as you would expect. More, however, presented with sudden cardiac arrest. There were also not only family screening patients in there, there were also those presenting with severe presentations of Brugada syndrome, more so than in the adult population, and a much higher yield of SCN5A disease beyond even just from the family screening perspective you would expect in terms of predictive cascade testing in these children. And consequent to that, I think an association of that, more sinus node dysfunction. And they actually found a greater risk amongst children compared to, in follow-up compared to adults. Looking at this survival curve over 5 years, you could see a much more rapid recurrence of events, about a 2% event rate in the population compared to about 1% in the older groups. So in their experience, children were just not all at low risk, as we may sometimes be lulled into thinking about Brugada syndrome in a pediatric setting. So in conclusion, Brugada syndrome relies upon the type 1 pattern. The provoked pattern alone does not mean Brugada syndrome. Risk really relies upon the presence of the type 1 pattern and syncope. And while childhood Brugada syndrome is rarer, its risk is not therefore lower. This may be related, as I said, to severe symptomatic presentation in probands, pediatric probands, a greater SCN5A burden in the pediatric setting, and a greater fever sensitivity as well. And so there's a focus really for pediatric patients on fever management, and maybe a low threshold for considering quinidine or hydroquinidine in order to prevent needing to leap to a defibrillator or to ablation therapy at a young age. And so I think we do really need specific age, gender, risk strategies that are appropriate to these patients. Thank you.